to the Latino Coalition's podcast in partnership with PhRMA. And we are going to discuss access, affordability, and innovation, what drug policy means for the Latino community. To get us kicked off, I'd also like to start by saying Happy Hispanic Heritage Month. It is a time where we celebrate Latino contributions across industries and segments. We enjoy fellowship and community recognition events. And it is also a time that we can have good, sound discussions and set the tone for important information that impacts our ability to thrive and advance as a collective community. Most notably, how policy decisions affect real lives, real access, and real small businesses like mine. Once again, I am proud that TLC and PhRMA are partnering together to spotlight how policy reforms can either empower or hinder Latino communities. And what we hope to explore today, with the help of our esteemed guest, Dr. Michael YBARRA, a few key topics. How and why are Latino communities across the nation impacted by chronic disease and access to treatment and health care? We will also explore how independent Latino-owned businesses, including pharmacies, we know they are community anchors, and importantly, they are being squeezed by drug pricing middlemen. So now I'd like to introduce our esteemed guest today, Dr. Michael YBARRA. Dr. YBARRA is the emergency physician and chief medical officer at Pharmaceutical Research and Manufacturers of America, PhRMA. As an organization, PhRMA advocates for public policies that support the innovative biopharmaceutical ecosystem. So, Dr. YBARRA, I think where we'd like to start would be just basically kind of an overview of, in your view, what's broken and who's hurt. So if you could start by giving us just maybe a summary of the 340B program and how it was initially intended to work. We can start there.
Sure. Well, first of all, thanks, CiCi, for having me. It's really a pleasure to be here, and particularly during Hispanic Heritage Month, where it's sort of a time we can all reflect on our values, traditions, and experiences that shape who we are. I'm an ER doc, emergency physician. I grew up in Southern California in a Mexican-American family, and healthcare and strong relationships with physicians were really deeply valued. But I also sort of saw firsthand how health challenges can really weigh heavily on families. My grandfather and grandmother lived long and meaningful lives, but ultimately succumbed to chronic kidney disease and dementia, which really are disproportionately impacted by within Hispanic communities. So it was something that I take with me. It's a big sense of responsibility that I carry into my own career. And becoming a doctor was not just about choosing a profession. It was really much more for me about finding a professional identity that was really rooted in my family's values. So you mentioned I'm an ER doc. I'm also chief medical officer at PhRMA. I'm here today to sort of share my perspective in that capacity as chief medical officer at PhRMA. But I've certainly seen how diseases like Alzheimer's, diabetes, even COVID-19, which I worked in the ER throughout, really take a significant toll on the most vulnerable. I see patients, as you mentioned, in Washington, D.C., and there's a large Hispanic population in D.C., albeit with a different level of diversity than what I grew up with in Southern California, where being Hispanic meant predominantly being Mexican American. Here in DC, there's a wide range of heritage that's represented, including a lot from Central America. And so all that perspective is really important to me, to be able to care for patients no matter where they're from, and try to understand as best as I can what their backgrounds are, and then carry that with me into the policy arena. And that's really what we do at PhRMA, is public policy. And I always think about that interaction at the bedside with the patient, and I think about how the policy that we're advocating for with respect to patient access, fostering innovation, building partnerships, how that can all really change lives. And it's easier said than done, because it's a really hard thing to make good public policy. And you sort of touched on one that we really focus on at PhRMA, which is the 340B program, which I think we're going to talk more about, and then PBMs and pharmacies. And so I really, again, appreciate the opportunity to be in this conversation and talk a little bit more about those issues.
Well, excellent. Well, I think, once again, for our audience, many people may not know what the 340B program is and how it impacts them. So we could start with that.
So I'm happy to give sort of a crash course on the program and how it was originally intended to work. It was started in 1992 as a relatively small drug pricing program to help patients access more affordable medicine. And so under the program, manufacturers sell medicines to certain hospitals and clinics at a steep discount, with the expectation that those savings would be passed on to patients who need it the most. So at its best, 340B is really intended to strengthen the safety net and reduce barriers to care. The problem is that unfortunately, with anything, it's grown really large over time. It's now the second largest drug pricing program in the US, second only to Medicare Part D, which is the drug program for seniors on Medicare. And I think for your audience that may include a lot of employers, it's something that could be driving up costs for your health insurance program. It's gotten a lot larger with a large sort of for-profit middlemen, not originally intended to benefit from the program, but for-profit pharmacy chains and for-profit middlemen that are profiting sort of off of the safety net. Unfortunately, there's limited transparency in terms of how the savings are used, and sometimes small and independent pharmacies, even those that might be Latino owned, could be squeezed out. So there's a lot of work to do there. There's a lot of interest in the program, and it flies under the radar, I think, for probably a lot on your program. But I think if we were able to reorient it towards the true safety net, more patients could benefit, and we could try to root out some of the discrepancies that are happening in the program.
So, I guess then from my perspective, and I'm a small business owner as well, so I face increased insurance premiums for myself, for my employees. I take pride in the fact that I can't offer health insurance to my employees, but it's sticker shock almost. It feels like every year.
Yeah.
And I know that the PBMs or the prescription drugs are a big piece of that, as you mentioned. So for our audience, what would be maybe the biggest misunderstanding about drug pricing today, and why should we care? Obviously, I mentioned one segment, which is small business owners, but maybe if you could expand on that.
Totally. Well, I think the biggest misconception or maybe the biggest surprise about drug pricing that folks may not know about is that 50 cents on the dollar goes to somebody other than the manufacturer who made the medicine. 50 cents on the dollar. I know there are a lot of, again, small business owners listening in. So imagine if your supply chain costs for everything that you were purchasing, 50 cents of everything went to somebody else that wasn't providing the product. So that's sort of the world that we live in. And unfortunately, a lot of people aren't aware of that. And I appreciate what you said, CiCi. I think a lot of small business owners are really laser focused on offering a wide range of coverage for their employees, at the same time controlling for healthcare costs, since rising premiums and out-of-pocket costs are going to directly impact them and their employees. So I think, again, getting back to that 50-cent statistic, while much of the conversation in healthcare costs tend to focus on the top lines, like how much is the hospital, how much is the drug, these sort of things that fly under the radar can actually have a really big impact. And you mentioned pharmacy benefit managers. PBMs are middlemen that negotiate drug prices and manage formularies. They play a really powerful but often opaque role in terms of determining what medicines cost, what people pay at the pharmacy counter. So I think for small business owners that are trying to do right by their employees, really understanding how these hidden factors influence overall healthcare spending is really important for ensuring sort of access, affordability, and importantly, transparency as well.
So, for example, when new innovative drugs, maybe might hit the market, like, for example, the diabetes, some of the diabetes medicine that was, maybe about a year or so ago, and even some of the weight loss drugs. I mean, so how does that, like, for those two particular, I guess, where are they at in this process? So employers like myself or other large employers can figure out the best way that they can, one, help their employees, for prevention, and then struggle with, the high costs of these new drugs, and, how they can positively impact our workforce and communities.
Yeah, that's a really great question. I think, one of the things that we've been trying to talk a lot about, again, getting back to that 50 cents on the dollar comment that I made a second ago or a few minutes ago, insurers and PBMs, they receive a lot of dollars in rebates and discounts from manufacturers that reduce the cost of medicine substantially. And yet sometimes, many times, patients are forced to pay the full price. And sometimes those rebate dollars are opaque to the employer, in your case, maybe the small business. Not only that, there's been investigations by the Federal Trade Commission because PBMs are so large and so powerful. They actually control 80% of the market. There's really three of them that control most of the pharmacy benefits. They also use other tactics to sort of capture savings in the supply chain, so to speak. So they might steer patients to the pharmacies that they own. They might cut reimbursement rates for independent pharmacies or Latino-owned pharmacies, for example. They mark up medicines at their own pharmacies in some situations as well, the FTC found. So it's really important that we have policies in place that sort of get at some of those conflicts of interest, because those practices are going to be driving up costs for patients. And again, they might be completely opaque to the employer and certainly to the patient. So I think those PBM business practices are really, really critical to get at, to cut through some of the opaqueness, to make sure reimbursement rates are fair for pharmacies, and making sure that there's not sort of onerous requirements on those independent pharmacies. I'd also be remiss if I just said, like, when I think about, again, health policy through the lens of patient care, just making sure that what we do, really cuts through to that doctor-patient interaction. All those discounts that are being negotiated feel a little bit, far away from me as a provider, but making sure that patients ultimately benefit from it, that they see lower costs at the pharmacy counter, is really, really critical. So again, there's a lot of work being done here. It's been many years in the making, but I'm hopeful that some meaningful PBM reform, either in Congress or in the states or in some of these regulatory agencies, could make a difference to improving care for patients.
It sounds like, and the work that you do, especially in the policy front, that Latinos could potentially lose twice, right? Both as patients and small business owners, if we don't try to get some of these policy decisions, on the right track. So to get, once again, so we can cut some of those costs in the middle.
Mhm.
So let's just go. Let's maybe take a different track now. And so we've identified what the issues are, the things that are driving up costs and making it more difficult to have the access that we need for healthier workforces and healthier communities. And so what are we doing about it?
Mhm.
So
Yeah.
what is pharma particularly doing about it? What can be done? So let's start with that.
Yeah, certainly. Well, I think, again, wearing my pharma hat, what we really are focused on is ensuring that the benefits of what's happening in the system really flow down to the patient at that point of care level. So as it relates to PBMs, it's making sure the benefits of all those behind the scenes negotiations flow to patients. And then with respect to 340B, another area that pharma is really focused on, making sure at the point of care that you can identify who a 340B eligible patient is, and then being able to help them access their medicine at a discount if they need that. And unfortunately, neither in both of those situations, either with the PBM negotiating the discount or at some 340B facilities, that doesn't always happen. So we're really focused on sort of those two key things. A low-income patient, has eligible or has access to discounts based on what's occurring in the marketplace now. So that's really sort of a sense of fairness that we at pharma are advocating for in terms of both of those programs.
So that's the access. Is that the 340B Access Act that?
In part, yeah,
Yes.
The 340B Access Act, it was introduced in the House. It's something that pharma supports. It was a bill that was sort of designed to bring more accountability and transparency to the 340B drug pricing program, ensuring that those discounts that drug makers provide actually reach patients and communities who need them most. So for Latinos across the nation, who might face higher burdens of chronic disease like diabetes and kidney disease and cancer, that could make a meaningful difference. We do work in coalition with others that are out in the community providing services. And this is happening in some settings. It's just not happening in all settings. So for example, if you go to, a community health center, which I had to spend some time in residency working at, they're required as part of their federal grant to provide discounts on medicines. to patients that are low income, but that doesn't always flow through to every person that's receiving the 340B discount. So again, we feel really strongly at PhRMA that those 340B benefits should flow to low income patients when they're given. And Access Act would do that among other reforms. So I think it's a good starting point, and we appreciate that. There's a lot happening in that space though as well. There's a lot of federal interest in it. The Congressional Budget Office actually just put out a report last week in mid-September or in early September, depending on when you're listening to this podcast. It said the 340B program is actually raising costs for the federal government because of the sort of incentives that it's putting into place. And there have been other employer organizations like the American Benefits Council that have written sort of similarly. So I think there's going to be more interest and attention in this. Again, it's something that flies under the radar if you're not at PhRMA. So maybe it might be a new topic for those that are listening, but it's important one, and it's something that with reform might be able to benefit communities and patients more directly.
And taking it one step further than what we were talking a little bit about earlier about some of the new drugs. I mean, they're innovative. They're innovative. They're coming through trials, or what have you, and potentially life-saving. And I'm personally a beneficiary of a clinical trial that saved my life. And
oh, very good. That's
yeah,
amazing.
so I definitely understand and know the importance of innovation and some of those breakthrough drugs. But it fuels jobs and economy. I mean, there's lots of other benefits. So maybe you can expand on that a little bit.
Yeah. Well, going back to my own experience, I graduated medical school in 2008. So I started in 2004. So it's not that long ago to me. My kids disagree. They think that was, eons ago. But one of the interesting things that I think about a lot is how in medical school, I learned about all these diseases that I've never actually seen in clinical practice. And that's really remarkable. A lot of them are now vaccine preventable. So, you spend a lot of time memorizing what measles, mumps, rubella, diphtheria, tetanus, what all these diseases are supposed to look like, and then you go on to never see them. Now, thankfully, we never see them because vaccines have prevented them. I'm concerned about how the tide might change, just given the current perceptions and conversation around vaccines. But I'm glad that I've never seen those things, and I hope that I never have to. I also think about a lot of diseases that the prognosis is just totally different than what I learned about in med school. When I was in med school, melanoma, the type of skin cancer, was a death sentence. Like that's what I remember learning about in pathology. If you had stage 4 melanoma, you were going to die. And I remember in residency taking care of patients on clinical trials for these, new innovative treatments called immunotherapies, and learning in a busy ER shift that people were having a different outcome than I expected them to, based on what I learned in med school just at that point, like 2 years before. And then, of course, I lived through COVID and worked in the ER in COVID. And the early days of COVID, it was a disease of suffering, death, and respiratory failure, because that's what happened to people that got severe COVID. And thanks to therapeutics and vaccines, we all think of it very differently now. Sadly, there is still too much, death and suffering with that disease, but it's not everyone experiencing that, and it's not the same level of risk that it was 5 years ago. And so that's what really gets me excited to get up every day and think about like, hey, a med student today is learning about a disease that our industry could potentially change the trajectory of, and that's not hyperbole. I'm really hopeful that if we keep doing what we're doing or have traditionally done in terms of America being a leader in science and technology and investing and rewarding innovation, that sounds lofty, but I can tell you in the 15 years I've been a doctor or a practicing doctor, almost 20 years now, it has happened and it could happen again. We just got to keep our pedal to the metal. We have to have the right policies in place to make those promising medicines come to the market.
Absolutely. And, you did touch on, the vaccine issue, the, COVID and, the importance of getting, the flu vaccine and still, the COVID shots this season. So, I think, maybe that's one of the takeaways from this is just to emphasize that it's still important to get those vaccines for this upcoming season.
Definitely. I mean, I started by talking about how, my family really respected physicians and trusted voices in healthcare. And I hope you have those trusted voices still. I know healthcare has changed a lot since I was growing up, but seek out, a physician, a nurse, a pharmacist that you trust and talk to them about, what might be recommended for you. But as we enter respiratory virus season, my kids are back in school now and they've already come home with the cold, and I just don't want them to bring back something more serious. So yeah, talk to your doctor about the respiratory virus season and what you might be eligible for, which is going to include likely flu, COVID, and then there's new respiratory vaccines as well for RSV, depending on your age. So these are really potentially game changers to keep us healthy and out of the hospital this winter.
So, before we close, I'd like to, ask you if there are 2 to 3, maybe from a policy perspective, in addition to getting your flu and COVID vaccine,
Yeah.
That this audience could take away in terms of, something that they can do as an influencer, a small business owner, or somebody that has, credibility in their community to help with the 340B Access Act or any of those policy that you will be focused on. What would they be?
Yeah. Well, I think, you hit on the highlights really, which is, let's sort of make sure that the system's working to the best that it can for patients and for employers, while at the same time continuing to incentivize that next generation of treatments. Again, like I want the med students today to be learning about diseases that they don't have to take care of, number one, or the prognosis is really different than what they're learning about today because of innovation. And so keeping in place the incentives, not putting in place harmful disincentives like changing or government regulation of pricing. The current flavor that you might hear a lot about is this most favored nation idea. We have a lot of concerns about how that could undermine the next generation of treatments. So sort of staying away from that, but then in our view, reforming the system by making sure patients benefit from those PBM discounts, that we get at the conflicts of interest in the PBM space, and then similarly making sure patients benefit directly from the 340B program. That's sort of the right way that we would approach this again, so that the next generation of innovations can make their way to patients, and doctors learning how to treat patients today have better outcomes in the future.
Excellent. Well, thank you very much for your time today, Dr. YBARRA. This was very enlightening, not only for myself, but I know for our audience as well.
Oh, thank you. Thank you. Really appreciate it. It's great to chat with you.